Future ahead of us, we see endless possibility. We started simply with the goal of raising the bar, expecting more, with the belief that healthcare education could be better, more effective, and more successful at producing highly competent, empathic healthcare professionals. We started with $15,000 and a dream. 20 years later, with over 6,500 graduates, millions of dollars of economic impact, thousands of patients treated, and innumerable lives changed, the future is a beacon burning bright. As our university has expanded, so has our mission.
Roseman University of Health Sciences advances the health and wellness of the communities we serve by educating current and future generation of health professionals.
Conducting research.
And providing compassionate patient care.
In our communities.
We actively pursue partnerships and affiliations that are aligned with our mission.
We work to create an environment which fosters both internal and external collaborations to achieve optimal outcomes.
And are committed to responsible fiscal management in all endeavors.
As we look ahead, we have so much yet to accomplish. We will continue to grow and expand our reach and support into the communities we serve. We look ahead to the next 20 years with you by our side. Thank you for being part of our journey. With you by our side, we are Roseman Strong.
Hi, and welcome to one of the first of Utah Business's live-streamed panel events. I'm Elle Griffin. I'm the editor-in-chief of Utah Business, and today we are going to be talking about healthcare with some of our state's utmost top health experts. Today we'll be speaking with Eddie Stenyum, who is the infectious disease physician for Intermountain Healthcare. We'll be speaking with Stephen Foxley, who's the government affairs director at Regions Blue Cross Blue Shield of Utah. We'll be speaking with Christine Ginocchio, VP of Scientific and Medical Affairs at BioFire and a professor of medicine at Zucker School of Medicine in New York. We'll be speaking with Dr. Frank Licari, Dean at Roseman University, and Gary Edwards, the Executive Director for Salt Lake County Health. Thank you all so much for being here with us to talk about healthcare. I know we are taking a few extra precautions today. We are sitting very far apart. We've got masks on when we're not speaking. But we are so excited to have you all here in the same room together to be talking about exactly what went down this year. We've had a very interesting year, to say the least, and I'm very excited to talk about this with all of you. But why don't we kick it off? Gary, will you take us through a little bit what went down at the public health level in the county and state?
Yes, thank you. It's been a very interesting year, and it actually started with public health at the end of 2019 when we started learning about this novel coronavirus in China and then watching it spread. Our staff has been actively involved in being on the front lines since back in December, working closely with the state health department and the other local health departments across Utah. In March, we had our first case, and that really put things in motion. After that point, as everyone knows, we had school closures. We closed down venues that were not essential for us to continue living. And we asked individuals to stay home. And those efforts were successful. We were able to flatten the curve. If we look at the epidemic curve, it was successful. We began opening things up and we saw an increase, and then we saw our first spike that we look at it now and it's pretty small compared to what we're seeing right now. But we saw a spike shortly after Memorial Day. We began to have increased testing and getting individuals involved in testing using face coverings, and we saw those numbers go down after some mandatory mask requirements. Made it through the summer fairly well. Granted, people are tired. This has been going on for a long time. People are tired of restrictions, they're tired of testing, they're tired of the whole message. And then getting our universities and our public schools, private schools back in session. We saw the spike that we're currently dealing with now, the surge, take off to where we are today. We are in very deliberate and serious preparations for receiving vaccine and having mass vaccination clinics, and hopefully we'll see that begin rolling out over the next 60 to 90 days.
Awesome. Now, a lot of you are in the healthcare industry, which a lot of things played out a little bit differently than from what the public saw. So maybe, Eddie, do you want to take us through what went down at Intermountain Healthcare? What have you been seeing?
How long do we have?
2 hours.
It was, Gary's kind of summary is great. Makes us think back to February, March, when we started to really think about how do we as a healthcare system that spans multiple states get ready for this. And we learned fast and we failed fast, and we activated so many different teams to be able to provide care and testing and everything we needed for our communities. And I think first was getting our testing platforms up and working with our central labs, with companies like BioFire and ARUP, and really standing up how do we test a lot of people. And we initially started testing in early March, and then we had 24 testing sites set up before the end of the month. And now we've done over 300,000 tests here in Utah. And then it was that transition to telehealth, as we needed to really hold off on surgeries, shut down on just traditional ambulatory care visits. How do we make that pivot to care for our patients, but in a different manner? And so turning on our telehealth platform across the entire state, and really ramping that up, getting all of our providers comfortable with it, and also the patients comfortable with it. We've definitely refined our practices and worked with the communities in terms of making masks and emotional health relief hotlines. And now we're in a phase where it's how do we manage the ever-increasing numbers of hospitalizations. And this is the critical phase that we are in. That is really unfortunate to be happening this far into the pandemic when people are tired of the pandemic. But now is when we need critical, bold, aggressive action to actually stem this tide. And we haven't had hospitalizations ever this high across our facilities, and we're having to do things in our healthcare network that we've never done before, and we don't want to do. For the first time in the past 2 weeks, we've had to open up a new ICU down in St. George because we couldn't accommodate all the ICU patients. We are now transferring our pediatric patients from Riverton hospitals to Primary Children Hospital so we can put COVID patients in those pediatric beds. We've opened up medical and surgical unit at Tosh, our orthopedic spine hospital, so we can take care of medicine patients, so we can put more COVID patients at Intermountain Medical Center. And now we're load balancing aggressively across the system so we can make sure those patients are spread out, and we are really optimizing our caregivers and the resources we have. So it's not atypical now for somebody to show up at Utah Valley Hospital down in Provo and get shipped to Ogden because that's where we have space for them. And that's just the first of kind of many surge plans. And we're going to have to keep activating these things as our hospitalizations go up, which they're going to continue to do for a number of weeks at the pace that we're accruing on.
You handling that internally, because that is clearly a new role you've had to take on, and you've probably seen this, Christine, as well, but where the hospitals are having to deal with, suddenly a brand new thing that they've never had to deal with, and you're now having to coordinate all these different hospitals that I'm guessing you're having to work together. What has that looked like internally? Have you had to hire new people? How have you done this?
Yeah, we haven't necessarily had to hire new people, but we're all taking on new roles. And we're getting very comfortable in those roles, and it's all about working together as a team and trusting in your colleagues that they will set up the system that you're going to need. And then we've also developed multiple new communication lines starting at the top and going through all of our providers, whether it be ambulatory care or the providers that work in the hospitals. And so it's setting up the teams, having faith in our teams, and then being able to communicate effectively to all of our staff. And we have 40,000 caregivers across the state of Utah. And so we've really had to be a cohesive unit to be able to pull these things off.
So have you had to use any new software? This is a business nightmare.
It's a huge challenge. What we have had to do is really leverage our electronic health record. So we use a EHR called Cerner, and we have teams that are able to allow us to modify that electronic health record in terms of ordering, for example, a COVID test. When you go to order, that's a new test that we had to be able to order, and now when you go and order a test, you put in key critical pieces of information into that order, and then we are constantly extracting that information out and looking at the outcomes of our work to say, what is working, what is not, how do we have to change this, what are the predictors we have in terms of positivity. And so it's really adapting the technology that we've had to really suit the pandemic. And that's been a really fluid process. Unfortunately, our teams have been able to do that with us and be able to accommodate those needs, whether it be from testing or setting up a research trial at 3 of our hospitals.
Yeah, I think the organizational power behind this has been really fascinating. And that's, Christine, why I want to talk to you next, because at BioFire, you were doing something totally different until COVID came along, and then you had some massive changes at your company. So will you walk us through exactly what you did this year?
So one of our primary scopes of diagnostic testing has always been respiratory tract infections. And we have many panels that deal with viruses, atypical bacteria. We deal with really true lower respiratory tract pneumonia. So that has been a main focus, but the company also deals with a lot of other infectious diseases at the same time. So meningitis, encephalitis, gastrointestinal infections, bone and joint infections. But RESPI was that was the first area of interest, and we've really grown to expand that. So when we started watching in December, January, as everybody else, what was happening, we had a lot of discussions about what's going to happen if COVID really becomes significant. But when you think back to the first SARS-CoV-1, that happened in 2003, and globally there were only 8,000 cases. So you really have to consider, do we shut down all the other diagnostics to focus on something that may not be a really global pandemic? So we had to watch that very closely. In the very beginning of it, we supported BioFire Defense that developed one of the first COVID assays for the Department of Defense. We took on a lot of their production to help support them. But then as we watched the pandemic grow, then we got the feeling it was time that we should step into it, and we really needed to. So the first things that we did was to take a look at our panels. So we don't make individual tests. We make broader, what we call syndromic panels. So if you come in with a respiratory infection, we can look at 15 different viruses. We can look at a number of bacteria all in a single test. So for us, it was having the ability to now add SARS-CoV-2 to panels that were already established. And they're very, very complicated panels. And normally, when we make a new panel or we change a panel, this can take us 3 to 5 years. It goes through the FDA, a long process. And because of the huge impact that we felt that this was going to bring, all the teams focused, all the R&D teams, everything focused on getting our first COVID syndromic panel out there. And from the time we started development of the panel through emergency use authorization with the FDA was only 40 days, which, like I said, would be something that would normally take years.
How did you do that?
Well, everybody focused on the R&D teams. They had to be creative. They had to do it in different ways than we did it. Now, the requirements for an EUA are not as extensive as for a normal FDA-cleared test. We work very closely with the FDA. They were tremendous partners for us to be able to get the tests in. They realized if we don't get diagnostic testing out there, we're going to be in really serious problem. So that was step one, to get the test cleared. Okay, now you have a test. You have to make a lot of that test. So that was the other really big challenge. So how do you gear up from making 50, 100,000 of a specific test to making 1 million of those tests. And that was probably the biggest challenge. It wasn't making the test, it's how do you gear up production. So when you look globally, you look at raw materials to make a diagnostic assay. Many of the large diagnostic companies use the same suppliers. So in the same way that you couldn't get a nasal swab or you couldn't get viral transport media, we were fighting for raw materials to make our tests. The simplest little widget in an instrument, but if it came from China and China was on lockdown, how do you make the instrument? So that was probably the biggest challenge, was our supply chain. And I can tell you our procurement people, all the teams that worked in there, had to work with the scientists. What do you need? What do you need for reagents? What do you need for instrument manufacturing? To find all kinds of different resources in order to get those materials in. And they did an outstanding job. And it made me appreciate supply chain, what that truly means to have a good supply chain. So we were able to gear up production, but then we also were in the process of moving to brand new manufacturing facilities. And luckily, they were completed in April. So in the middle of this chaos, it was very stressful. We were also relocating manufacturing, but that extra 300,000 square foot of space would give us the future potential to really bring up all this testing. And then for the instruments, what we did for that, we doubled the amount of the engineers and the ones that assembled and the quality control people, because if you don't have the instrument, then you can't do the test. So just by the third quarter of this year, we had built over 1,900 new units and have 16,000 of them globally. So it was a huge coordination to develop the assay, to make the instruments, and then have to put it all together. And unfortunately, we can't make every COVID test that everybody would like. It's just physically not possible. So we're moving ahead now with new production lines, new facilities to be able to continue that supply. And moving forward, we've got a rough year to year and a half in front of us with COVID. So diagnostics has really been key in making sure that our healthcare workers are protected, that they know which patients have COVID, that the families are protected. So for us, it's really a key responsibility of the company that we really needed to do this. So we have 2 different COVID tests that are available now. We have one that's based for the hospitals like Intermountain Health, which uses it, but we also have one now that's approved for a physician's office for point-of-care testing, which is another really critical site that you could go to your doctor, have it done right there, and then this way you would know what that result would be. So, and we have other ones still in development. So it's been exciting, frustrating, very anxious, but a rewarding time.
I mean, I'm amazed at how a lot of these Utah companies were able to assemble these things so quickly. And when you talk about supply chain and getting these things done in 40 days, I mean, are you competing with nationally for those resources, internationally for those resources?
Yes, we are. Just simple things like to isolate the nucleic acids that we detect in the test, those reagents. Many big companies have 1 or 2 of the same suppliers. So if we want to make 1 million tests, Roche wants to make 1 billion tests, BD wants to make 1 million tests. So everybody's juggling for the same resources. So, yeah, so it was quite a difference. We went through the pandemic in 2009, the H1N1, and we had to bring up diagnostics. I was in the hospital at that time very quickly. But we already had influenza A tests. It was a matter of supplementing. We have coronavirus tests, but they don't cover the new coronavirus. So it was something, when you bring up something from scratch, it's really, and no one could have expected the amount of people globally that would be infected with the coronavirus by now. So and we don't serve just the US, we don't serve just Utah, we serve the entire world. So we have to think about all our external customers also and keeping them with COVID tests.
So what made the difference between a company that was able to get the resources nationally and internationally versus a company that didn't?
Well, as an international company, I think that was very beneficial because, as you know, BioFire Diagnostics started as Idaho Technology, a small startup company. They became BioFire, and then they were bought by bioMérieux, which is a huge global company, and they have a lot of global resources. So having our parent have that ability was really very, very helpful. So teams from all over for procurement worked together to try to get us the resources we needed. We have other diagnostics that we offer in Europe. They were faced with the same difficulties in getting reagents and supplies. So, and I think it's easier maybe for a bigger company and much harder for a small startup company, say, when you're the little fish in the big pond and there's so much competition. But it was also a lot of creativity on the part of our supply chain people, where to go to, look for other avenues and resources. So.
Yeah, I think that's a very common thread this year is let's scramble to get this together, let's adapt, let's do this quickly. And we see that certainly on the hospital side, on the public health side. I'm curious, Stephen, how did this play out in terms of that as a healthcare provider, Blue Cross Blue Shield, huge. What kind of changes did you have to make to be able to make sure everyone's care was taken care of?
Yeah. Thank you, Elle, for having us today. And we're in a unique position as we've been here in the state for 75 years, and people count on us to be there to make sure that their claims are getting paid and to finance and protect their health care. And we're in a different position from some of the people here where we don't provide direct care, but we want to make sure that our members are protected. And we operate in 4 states, and early on saw the coronavirus in Washington and Oregon, 2 of the first states where we operate, and seeing that in January we did a stress test of our IT systems and said, let's send everybody home and make sure that if this does kind of come and really become something bigger, that we're prepared to handle that. And so we sent everybody home and we learned lessons, and then we had about 30% of our workforce which was working remotely prior. So we were in a good position to be there and support our members. And then as we moved farther into the pandemic, and we kind of looked at where can Blue Cross as a community support Utahns, and that's with our members, making sure that they have access to the treatment they need, to have our nurses calling, make sure they have access to food, seeing the kind of challenges in the nonprofit community, making sure that we're supporting our nonprofit partners, especially in areas like food scarcity, and then businesses. I mean, 2/3 of Utahns get their insurance through their employer, and we wanted to make sure that businesses were doing all they could to stay safely open, and we helped them with education, and then also supporting them and making sure that they had the benefits they needed for their employees, and giving them the flexibility that they needed to be able to offer those throughout the year.
Yeah, that's really interesting because in Utah we had a lot of layoffs, a big round of layoffs, and then a big round of hiring almost immediately after. You must have been seeing plans fluctuating as people get off, get on. How were you making sure all those people were cared for during transition?
Yeah, we were lucky. All of our plans had options for people as there were furloughs, so that employers could keep those furloughed employees on. And many employees, even when you did have those hours cut back, were worked to make sure that their employees stayed covered. And then the other thing, we worked on mid-year benefit adjustments, and then kind of grace periods and things like that, financial support. We provided a $35 million in claims relief to our employers in recognition of kind of the financial hardship that they had been experiencing this year.
Did you have to make a lot of any policy changes in terms of healthcare coverage? Like
most carriers, we were very early, even before federal and state policy, on making sure that everybody had access to no-cost testing for diagnostic purposes, and then waiving cost sharing for COVID-19 testing and treatment. We'll be doing that at least until the end of the year. And, the other big thing, like Dr. Stenyum brought up was that virtual care has been really a real silver lining for the pandemic. We saw our claims volume for telehealth visits jump by about 49 times across our footprint. That's since come down quite a bit, but making sure that we had relaxed policies there so that members could shift to those types of services. And then, we also enhanced our provider payments for telehealth services, that we've been doing during the course of the pandemic.
Yeah, that's interesting. I feel as an end user that we didn't see a lot of what you saw. We were just getting our mask for free in the mail, working from home, and you must have seen extreme costs to pivot so quickly in every aspect. Was that ever a factor for any of you, where you had to take on a lot of cost unexpectedly? Eddie?
Clearly,
yeah.
Right? If you look at what just happened in terms of our volumes, whether it be in urgent care, family medicine, or internal medicine, they essentially plummeted. And not to mention the fact that early in this pandemic, we stopped elective surgeries. And so people weren't getting the hip replacements, the back surgeries that they needed. We don't like to use the word elective because there's nothing elective about the pain you're having from severe osteoarthritis in a knee, for example, but they were non-emergent surgeries. And so, yeah, we did feel that, across the system as we were shutting those things down temporarily. Fortunately, Intermountain came from a place of strength financially, and we were able to weather that. And we have a large proportion of our lives, protected in a fee-for-value type service. And so it definitely impacted us, but we then were able to shift them back and get them back into care and get them back into care safely through telemedicine or through appropriate, personal protective equipment. But it was a big deal, and you could probably see across the U.S. Healthcare providers getting laid off and getting furloughed. And fortunately, within our system, we didn't necessarily need to furlough people, but we did have to redeploy them. And so we took operating room nurses and redeployed them to our testing tents, and we taught them how to do our triage line for the COVID hotline or staff the emotional relief hotline. And so being able to pivot a lot of those employees into different positions and allowing them to have that flexibility allowed us to continue to keep them getting paid. But yeah, it was a tough time early on, and we're still seeing the effects of it. Our urgent care volumes are not going to be back to what they were, and I think that's going to be something that we're going to have to realize moving forward.
Yeah, that's interesting, and I think this is making me think of Roseman, because you're in education, you're having to teach medicine semi-remotely or non-remotely. You'll have to tell me how you're doing that. And you're also maybe having teachers doing things differently, where you have to readjusting teachers. Tell me what that's like at a teaching institution during all of this.
Right, so we are a health professions university exclusively, and we run a large clinic too, so we had two elements we were running at the same time. And getting the online was not, we closed down on a Friday, we were up and running in 3 days. And so our faculty pivoted pretty well with that environment, and so did our students, they did. It was amazing that some faculty who aren't technology savvy, let's say, were able to teach courses, and we began to do, we actually worked very well with it. We took on live courses. So they were scheduled to do a lecture, they gave that lecture live when they were doing it, and we had small group work that they had to do too for the students to do. And eventually they all adapted to it and did that. Where the clinic was, we run a large dental clinic on the South Jordan campus here, and that clinic we had to shut down and only go to emergencies only, so urgent care, and we treat people. And then we began to look and say, okay, what are we going to do to get back up and running? And we focused on safety. So then it was, okay, how do we safely get the students back? How do we get the staff back and then the patients back? And one of the things that we do that we were concerned about was the aerosol generating procedures that dentistry does. So we had to get a lot of data to understand how that's generated and what you have to do to protect everybody against it. And we began to work out protocols then during the interim when everybody was off campus to see what we needed. We had the same PPE issues that you did, and looking at it. Cost then was looking at how do you acquire it, get it. Our cost per patient went up looking at it. So what we used to do about less than $10 for 2 students and to treat a patient went up to over $40 to do that. And so we had to absorb those costs initially to be able to do it. But we're also in a sort of a strange position in which we have to educate students to graduate and do the things. So we need a patient care system that supports the education of our students and do that. So we had to work through all those issues to be able to be successful and do it. And we took one of the issues at a time, but used safety as the top level of it. We had to be safe. Everything on campus got changed. We quickly took out tables, took out chairs with facilities. We went to touchless everywhere we could. We went on a schedule where everything was wiped down, so people, when they came in and did it, and we got back up and running in May and got people back on campus in August, and have gone to hybrid education since then.
Did you see enrollment change this fall?
No, surprisingly, a lot of people, because it was funny, I was getting calls this summer from students who wanted to come, and they felt secure. In fact, I even had to talk to some parents. They felt secure about Utah because our numbers weren't high then. If you were coming from the East Coast, New Jersey and New York especially, where this summer was very bad and they had a lot of cases and it was a tough place to be, Utah did not have those numbers. So families felt secure in sending their students to Utah to go to school and to Las Vegas, our other campuses in Las Vegas. So we were okay, with that, and it actually worked in our favor initially to do those things.
Did you or any of you really have cases happen internally at your organization where you maybe had to lose some employees for a bit and it became harder, maybe you lose some teachers, some doctors, and you're kind of having to deal with staff and making sure everyone's taken care of? Was that a factor, or is it a factor right now especially? Stephen?
We have about 99% of our workforce is currently at home, but of course, given the amount of community spread, we do see employees who are forced to quarantine or take time off, and I've been amazed at how well everybody's been able to pick up work and make sure that we don't miss a beat.
So I don't think there's any institution or business that has not been impacted, that has not had employees. I mean, this is part of life. People go home to their families and there could be exposures. So the non-essential people, the people that could work from home, all of those people were sent home to work remotely. And Zoom and WebEx and Teams did quite well for that. But we have this whole group of essential people. We have 1,000 people in manufacturing. We have hundreds of people in instrument manufacturing, the R&D scientists that need to come in. So very early on, we had teams that met. It could have been daily, weekly, to set up our own infection control practices. At the facility where we limited people coming in. You talk about, changing the facilities. Every table and chair in the cafeteria went away one day because you couldn't sit in groups. We had to teach them about masks and social distancing, a lot of people that had never done that before. People in manufacturing were a little bit more conscious of that because they do wear a lot of protective gear to protect not only themselves, but we have to protect the products we make too. So in the beginning, it was changing every single day. Every day, new guidelines came out from the Department of Health or the CDC or the WHO. So we had to be really quite flexible. And even on our side, to get PPE was really, really difficult. But yet we had to put people in PPE also. So, of course, we've had cases. I think they've been minimal considering the large volume of people that physically have to come to BioFire. And it's unavoidable. And we keep a lot of people in quarantine. Anybody that has any type of respiratory symptom cannot show up for work, no matter what. And if they have exposures, we follow all the CDC guidelines. We have people tested. So I think we've done a really good job in trying to really minimize the amount of exposure, but it's inevitable. You know, people get it and they say, I did everything right. Where could I possibly have gotten COVID? You know, so it's really difficult to say you're not going to have a case. It's not going to happen.
Yeah, Eddie?
Yeah, you're right. I think the point should be made too is that we've all probably suffered that from our respective companies, and it's going to get worse. I think is the biggest issue we have to kind of think about here. Within Intermountain, yes, we've had employees turn positive. We've had employees have severe disease. Fortunately, very few of them have been linked back to caring for patients within the hospital or in the clinic. And the vast majority of the cases that we see within Intermountain amongst our own employees are outside. And they're in community circles and social circles or in their families, which is what's really driving the spread right now. And when you look at where are we going, 2,100 cases reported today, 32% test positivity, which is just a mind-blowingly high number. We're going to need to be adaptive to be able to say that this is going to happen more and more as we go into this winter season, and how are we going to adapt to that? And we really need to take this mentality of, like Christine said, if you are sick, you do not go to work. You do not go out. Even if it feels like the common cold, that could be coronavirus. And so it's going to be this really changing of the mentality of like, this isn't a personal decision where I can go to work or school and be effective or learn. This is, I can't go to those places because I need to protect our community. And we're really going to need to focus that as we move into this winter season. And as our cases are just out of control at this point.
I'm curious what you think, because a lot of businesses have put rules into place saying if you test positive for COVID, you get 2 weeks off, take care of yourself, don't come into work. What happens if you get a negative test? We've started to see people say, oh, well, I don't want to get a test because I need to be able to work, and if it's negative, then I'm still going to have to go in, or is that a factor? Gary?
Well, even if somebody has gotten a negative test, if they were tested because they were in close contact with a positive case, they still have a 14-day quarantine that they need to comply with. So the test just tells you, here's where you are right now. But you've got a 14-day period where you could convert on any one of those days.
Okay. Do you recommend people coming back in and getting a test if they get sick after that?
If they get sick after?
After a negative test?
Yes, because we want to know of all of the positive cases so that we can do contact tracing, identify where they may have been. And hopefully they've been home, but we can talk to them about their family and what their family needs to be doing, because their family members have now been exposed. So yes, it's really important.
Yeah, how has contact tracing been going on? Obviously these four are working in healthcare and their employees are probably being more careful than most. Maybe the public isn't quite as diligent. How has that been, trying to keep contact tracing going amidst all of this?
Well, it's very challenging. Each case has multiple contacts, and our goal is to try and make contact with each one of those individuals. I'm sure all of us on our cell phones, it rings, it's a number we don't recognize, we don't answer it. And so that is a lot of what we're dealing with. Many people are good about listening to the voicemail that's left and following through. And so we are able to still make contact with most individuals. However, that just delays it that much further. We have the delay from the test being reported and then the delay in contact. And if that person is positive because of that contact they've had, they're unknowingly out in the community within their family spreading the disease.
Yeah, that is super interesting. And what are you seeing as being the number one reason why somebody would, is it public events? Is it being at work? Is it just family members? Where are these cases congregating?
Family and friend contacts. You know, when we go out, if we're out just doing some shopping, we know stores are expecting us to wear masks, to be social distanced. Even when we go into a restaurant, we are expected to wear a mask unless we are actively eating or drinking. When we're home though, we let our guard down. Our home is a safe place. We invite people in who are safe. We let our guard down. They let their guard down because they're coming to a safe place. They're not thinking that they might be in the early stages of an illness and expose somebody. That's where we're seeing a lot of this surge that is taking place.
How has your job changed this year compared to past years? I imagine you've changed it quite a bit.
I do nothing but COVID-related activities. One of the things I've loved about being in public health is it's so broad and diverse. I can deal with immunizations in the morning and a policy issue around septic systems in the afternoon, just incredibly broad. But every day, all day long, all night long is COVID.
That's interesting. Are you all in the same boat on that? Pretty much. Christine, did you want to say something?
I said, well, certainly COVID was a huge, tremendous focus for everybody, but in our field, we have to still continue to supply, like I said previously, diagnostics for all the other infectious diseases, and we can't stop development on new projects. So COVID is a huge part of our day, but we still have that other full day on top of our COVID day. So it's been quite a challenge, but rewarding because we're helping public health and keeping people safe. But I think everybody's looking forward to someday a downtime.
You guys want a vacation?
One other, to Gary's point, I think that COVID definitely is the focus of a lot of work right now, but COVID has also brought up other things in the healthcare system that maybe didn't work well for individuals or other health inequities. And so I think that COVID is the lens through which we're looking through a lot of things. But ultimately, I think that public health, really, there's a lot of opportunity to advance healthcare for individuals and make a system that works better for them.
Yeah, I am curious about that. We have made some changes this year. What are some of the changes we've made that maybe might stick around even after this?
I think when you look at healthcare, so many changes have happened. The focus on telehealth is not going to go away. We've found that to be such an effective tool to communicate with our patients, whether it be through their MyChart or through a true teleconsultation where they're at their home and we're seeing them virtually. We've gotten very good and adept with that, from our Connect Care clinic, which does that all day long, and that's all they do, to our primary care clinics that do that intermittently throughout the day. We're not going to let that go because that is a value that's going to be so critical to healthcare moving forward, and that's what consumers want. They want care when and where they want it, and if they can dial up and talk to their doc on their phone, that's what they want to do. And so I think that's just one component of many that is not going to go away, within healthcare.
Yeah. Gary?
One of the things that has been really obvious to us in public health, and I know that Intermountain has been working in this for a while, is it's the concept of social determinants of health. That we see individuals, lower income, and ethnic and minority groups that have higher rates of poor health from a number of different things. It's not because physiologically they are more susceptible to those infectious or chronic diseases. It has to do with these social determinants that are part of their life. And we're seeing that play out right before our eyes with COVID-19, as we have much higher rates in our ethnic minority populations, our lower income populations, because they're not able to stay home and work. Their job requires they are there serving a customer. And that puts them at greater risk. They go home, they live in a smaller home. They might have extended family living with them in a smaller home. And so there's greater opportunity for spread within that household. The individual goes to work, they have to work, they bring it home, and it spreads to that household.
Are you making changes in public health to try to affect that now or going forward?
We have implemented changes prior. This is helping us help the community realize that there is a need to have additional focus in certain areas of our population. We have services that are available to everybody, but we need to focus some services specifically and target other populations to make sure that these situations can be addressed before they become a problem.
And this has kind of helped that move
Yes.
forward. Okay,
Yes.
yeah, that makes sense. Christine?
So one of the big focuses prior to COVID, I'm on two committees. One is the Infectious Disease Society of America, their diagnostics committee, and I'm on the Presidential Council for Combating Antibiotic Resistance. And two of the main goals of that is to prevent the spread of these highly multi-drug resistant bacteria that we're dealing with in the hospitals and other places. But key to that, and one of the core elements of the PACCAR for the President's Council, is focusing on rapid and innovative diagnostics. If you can't diagnose the disease, you don't treat it properly. We're giving a lot of antibiotics for viral infections that we shouldn't be given. So one of the things that I think has been a benefit that's come out of this is the fact that we need diagnostics. Diagnostics is a key element in combating COVID and identifying those patients with COVID. And indirectly, this will be a huge benefit, that it has also brought a lot of government funding for the development of innovative diagnostics. It's given funding to small startup companies that don't have the capability of taking that diagnostic out into the commercial world. And so that's been a real boom for really pushing diagnostics in the community setting and appropriate use in the hospital setting. And the other thing is that one of the things that we deal with, and I dealt with it on the healthcare side and we deal with it now on the diagnostic side, is that reimbursement is a tremendous issue. We can't get health insurance companies to pay for diagnostics in different settings and in different patient populations. And not only private payers, but CMS. And we work closely with them, but this is a real problem in people being able to get reimbursed for a diagnostic test. So I think hopefully one of the benefits will be that the payers will see there is, in the right situation, there's a real great value. And we spend millions of dollars a year in the company doing clinical and health economic outcome studies to show the benefit of a diagnostic test. And it's actually, you know, a test ends up being the cheap part of the patient care when you can reduce hospital length of stay, you reduce antibiotic use, you prevent secondary infections like C. difficile disease. So I think that's going to be a change in healthcare that I hope will keep going through after the pandemic is over.
I absolutely 100% agree with everything Christine says. I would actually probably add on to that, is to say, just take a moment and look at the advancements that we've had in science in terms of identifying and treating patients with this disease. And we had no therapeutics for this disease starting in January. And now we have an FDA-approved drug, we have steroids, and we have multiple new agents that are really probably on the doorstep of getting EUA in the next few days to weeks in terms of monoclonal antibodies as a potential method to treat outpatients. And so I think it just should be recognized that the platforms that have been set up to detect and learn how to treat this virus could be very well used for a new multi-drug resistant bacteria, or one of these bacteria that we can't treat with our modern antibiotics. And there's so many parallels in terms of payment, in terms of novel antibiotics, and the fact that these are drugs that we make, and you have people like me say don't use them until you only need to use them, and then only use them for a short period of time. And so clearly there's a reason that drug manufacturers don't want to go in that business, right? That is not a profitable business, but we need to really identify what are novel mechanisms to really incentivize, drug manufacturers to get into that business, and payers to say, yeah, I get it, that's an $8,000 7-day regimen, and that's okay. And how do we pull that out of DRG funding within a healthcare system? So I think the platform that has been really highlighted in diagnostics and also in research within infectious diseases can now be applied to any number of different things. And I'm hoping that that continues to be a highlight and a focus, both at PACCARB, IDSA, and these other national organizations.
So we've sped up innovation in healthcare in a lot of ways. Is that what you're all seeing? That's super. Were there any challenges that maybe this did away with some things you didn't like before, or?
I mean, there's been huge challenges. I'm sure. Within just the thinking about research within Intermountain Healthcare, we weren't a big trialist center. I mean, that wasn't our focus of research. But we had to make it our focus of research. And so now, within a month, we stood up 2 large community-based trials in conjunction with the University of Utah to study multiple different medications, including the controversial hydroxychloroquine. And now we've got multiple NIH-sponsored studies in both inpatient and outpatient. And we didn't have that platform to begin with. And so we had to spin that up, create it, and now we've got a mechanism to provide access to these new drugs to patients that come in, whether you come in down in Utah County or in Salt Lake County. And it's something that was new and challenging for us, but now we have that platform built to be able to offer that access.
Yeah.
One other challenge here, I do think, there are systems and groups that do a good job with our fragmented healthcare system, but ultimately it still remains very fragmented and doesn't pay for value in the ways that it should. And I do think that this year has brought up some of those challenges, but I would really say that there's a lot more opportunities, and I think that many of the healthcare systems and payers, providers, I think there will be a newfound interest in working together in a more collaborative fashion.
How about in healthcare, right, or in education? I'd imagine you probably found some hurdles with going remote teaching in some ways, but maybe even some strengths there.
One of the things we found out, and the minute we went online, we noticed that there were more students in lectures than there usually were, and we were all pretty well shocked by that. But they participated, they did it, they took it seriously. The question part of it, they liked the technology of being able to chat and ask questions. And they worked on other issues that go with that. We also then were worried we had our examinations and assessments online too. We wondered, was there any impropriety happening? We reviewed all those things. We noticed that there was none with that. So that was another thing that we could look at. The possibility then of looking at going forward, I think from our university, is what can we do online? How can we utilize it? We took a totally in-class courses and went online with them, and now we're trying to sort out what can we look at and have as online courses going forward with it. So it's been a good experience for us to do that part.
Yeah, that's very interesting, because like you're saying, if the online lecture works, right, keep that part of it, right, but maybe some of the in-person work needs to continue being in person.
Correct. That's really what we're looking at. There are some things you have to, obviously, if you have to develop clinical skills, you need that with it, and looking at it, and those are part of the things that we did. We also nationally looked at changing licensing exams have changed from live patient or patient experiences to simulation experiences, so those have been other big changes that have happened, and they happened rather quickly to do that, because they know that they weren't going to be able to license people without some sort of examination like that.
Wow, well, that's really interesting. So we've had a lot of innovation come out of this year, a lot of changes, a lot of adaptation. We are going to spend the next hour talking about going forward, where we're going to go from here, but I want to take a quick break before we do. We're going to take a 10-minute intermission, and then we'll be right back at 3:05. I just want to thank Roseman University, who's our partner on this event, and this event would not happen without them, so thank you so much, Frank, for being here, and to Roseman. I also want to take this intermission to thank a bunch of our healthcare heroes. Every year, Utah Business honors about 20 people, organizations and individuals who really made a difference in healthcare. And this year we had a ton of submissions, a ton of people who really changed around their whole lives, their whole careers to help out this year with the pandemic. So we're going to introduce you to some of them during the intermission, and we'll be right back. Thank you so much. Welcome back. Here we are with the second hour of our deep dive event into the state of healthcare. We want to use this second hour of the event to talk about where we go from here. You know, we're looking at 2021 and beyond. Before we get started, I do want to thank some of our sponsors who helped with this event. We have Bind, BioFire, Digital Bytes Production and Design, Intermountain, Kiln, who's hosting this amazing space for us, Blue Cross Blue Shield, and also Salt Lake County Health Department. So thank you all for your sponsorship. And of course, thank you to all the healthcare heroes we saw during the intermission. All right, coming back, we're looking at 2021 and beyond. I was just talking to during the break to Frank, and we were talking about looking at recruiting the next generation and what that's going to look like going forward. So how are we doing that?
Well, this is the first time that we're recruiting almost exclusively online, and it's going to be a virtual event, and we're trying to make it as good an event as we can with it and look at it, but we're concerned, not overly. We draw students from all over the United States, and Utah sells to our here. It's a beautiful place. It's a safe place. The school we have, Roseman's facilities are beautiful, and it's a nice campus to be on, to look at. So we want to make sure that virtually we capture those elements with it when we interview students. And we're going through the virtual interview to make sure that we get the information that we do, and that we capture everything from the candidate too, to make a good decision with them. So we think we've got a good plan in place for this year, but this is something that we're doing, and it's going to be something that I think we're going to have to work through and make sure that it gets us exactly what we want. And is a good event for the candidates that come in too. So that's something we're looking very closely at.
So how will that work with new students? Are they going to be expected to move to Utah still, to still be present?
This year, you know, what we did with this year, we did require that. Most of our programs have an on-campus component to it. So, you know, dental school, nursing school really have a large on-campus component that they have to perform. We need them to treat first on simulation and then treat patients in the clinic. There's a rotation that goes with that, and our pharmacy students also have a clinical year that goes with it too. So everybody was required to come to Utah or our other campus in Las Vegas and be part of the campus environment that went with it and be part of it. So I think that's something that we'll look forward to the same in the future too.
Will you maybe batch it differently so people can do parts of it at home or parts of it in person, or how do you imagine that changing?
I think we're going to go with what's happening with the coronavirus right now, and whether we get testing and vaccination and other things that go with it. There's still some major advantage to being on campus and being part of that. We understand that there is some other components that we could teach well from home, and your virtual environment that we could set up with that. And I think, you know, as always, we're going to look to optimize those elements with it. The things that we do really well on campus, we're going to do well on campus, and the things we can do from home, we're going to allow those individuals to do it from home too. So we're going to try to come up with the best type of curriculum that fits the needs of our students as we go forward.
Okay, interesting. And how does, I know we talked just before the break about some of these innovations we've been seeing in healthcare and how we'll probably take that going forward. We'll start to get more into telehealth next year. You know, we'll hopefully be in a better place county-wise next year. Now that we're not quite a year into it, but we're almost a year into it, what have we learned that we think maybe we'll do differently next year? Or is it just going to be still fly by the seat of our pants? Yeah, Gary?
We are preparing for mass vaccination, and we have learned a lot from doing mass testing that can carry over to mass vaccination. How to handle crowds, how to prepare for unanticipated changes in weather, to prepare for or to anticipate you're thinking you'll have 300 cars, and instead you have 650 cars, like happened last night at our testing event. So we are learning from those things so that we can be perhaps, hopefully, better prepared with not the same thing, but a same kind of model moving forward. Our anticipation is that COVID is going to be around for a while. We're going to have a vaccine that will help us to a certain extent, but this is still a novel disease. We're 9 months, 10 months into it. We still have a lot to learn about this. How effective is the vaccine going to be? Is it going to provide 3 months worth of immunity, 3 years worth of immunity, 3 decades worth of immunity? We don't know that yet. Typically we have much longer vaccine trials, but this is being moved through quickly, not in an unsafe way, but moved through quickly so that we can hopefully get a larger proportion of the population with effective antibodies to protect them so that it's not everybody having to be sick in order to develop antibodies. So still a lot that has to be learned because it's a novel disease.
Yeah, I think it's really hard for us to look forward to next year. And the reason that it's hard for me to look forward to next year is because of what we're facing right now. I mean, we are at a healthcare crisis right now. At the rate of hospitalizations, we are going to be out of healthcare workers that care for the people that are in our beds. And so it's really challenging for me to be looking forward to next year because we haven't addressed the crisis in front of us. And so something needs to change now, and it needs to change in a big way for us to alter the course of this. This isn't just recommending mask use. You know, that's not going to get us out of this current situation. And so I think it's a little bit challenging for us to look forward to what will happen with vaccines or routine testing or how healthcare is going to look when I think everybody is so anxious and scared in healthcare about what's going to happen next week. Because we're getting to that critical point where we're going to be calling in nurses and physicians that don't care for these patients or trained to care for these patients and asking them to care for these patients. And so I think, it's hard for us to, have that lens right now. And, I do think we'll get up and over this peak, hopefully sooner than later. But we're going to then be dealing with still sound public health measures all winter. I mean, we're not going to have a vaccine available to us to be able to mass vaccinate by December. We may have some vaccine that we're going to be able to give to critical workers and people that need it most, but it's not going to be a vaccine we're going to distribute to everybody before Christmas. That's just not going to happen. And so I think we can't forget the fact that we're going to be in this situation through this winter and really have to abide by really strict, good public health measures, which means reducing our close contacts, wearing our masks, washing our hands, and not getting ourselves in situations where we're going to have high rates of transmission.
Well, I do think there's some positives that are going to come out of this. One is I think we're going to continue to see declutter, less people in the waiting room. The way that you'd go to the doctor and everybody wait in the waiting room, and it could be now, the way it is, we'll call you when I think that's going to continue. I think that's a good thing. I think that people want to wait less and do things less with it. I think we're much more considerate of patients' time. I know we've cut our appointment times down to 1 hour so that they're not in the building long enough and improved the way that we treat. I think we've figured out ways in which we can do things with the digital technology in terms of treatment that we don't have to do as invasive procedures with them, and that'll continue with looking at it. So I do think on that component, that's what we're going to see from the clinical side. I think from the healthcare business side, I think we're going to define employee and what an employee is and a work week is, and does everybody have to be on site to be an employee and to work and have an office? And I think we're going to look at that definition happening along this way too, and it'll be an interesting but different way in which all of us look at the way we work work together and have a work team together.
Yeah, we've even seen some of state employees saying state employees are going to start being remote or have a remote option, which is very incredible. Christine, did you have something you wanted to add?
So I think for us moving into next year, like we said, we can't predict what's going to happen in a month or 2 months or 3 months from now. Our main goal is to be able to use our brand new manufacturing facility to gear up production as fast as we can. It's not easy. There's a lot of automation that needs to be brought in and validated to do this type of, to make this type of test. But that's going to be really the big focus. We focus all our efforts on just COVID tests. I said we have all these other infectious disease tests. You come in with meningitis, with your child, you don't want them to say, well, we don't have that test anymore. So we really need to think about what's the fair distribution of that. And part of that is to gear up production as much as you can so that we can continue to supply all the infectious disease diagnostics. And then we also have to think about where are we going to be a year from now or 2 years from now when COVID becomes, and I truly believe it will, maybe it'll take us 2 to 3 years like it did with the Spanish flu, but it'll become a normal winter coronaviruses. There's many other coronaviruses that we see, but it has to set its clock and become part of that. So when the main focus is no longer coronavirus, we need to be at a place where we're still moving diagnostics ahead. So you come in and you have a infection in your knee, you can drain that knee in an hour, we can tell you what the pathogen is. So we really don't want to stop focusing on where the future is going to be, but yet COVID, it takes usually a tremendous amount of, say, the manufacturing resources. So I think that is where we know manufacturing has to increase no matter what the tests are, so that's going to be a really key focus. But then we're really now focusing on, we've made our COVID tests, we know that they're really good, and we'll now start to move on to making sure that all those other diagnostics stay on track for the future. It may be a little bit delayed, you know, the FDA is very focused on just COVID diagnostics right now, but from our standpoint, you know, we have to keep moving forward with everything else.
Where are we going to be from the county level? Things are changing day to day, but I mean, we're seeing different social guidelines we need to adhere to in different counties, passed down from the state, some at the city level. Is there some of that you imagine you'll be monitoring over the winter?
Well, we'll continue, yes, to monitor that. You know, the legislature and the governor's office have weighed in. This disease is a very political disease. And a lot of the things that are done are not driven by public health or by public health or medical science. It's driven politically. That's a concern I have moving into 2021 and beyond. What will be done to the ability of public health to protect communities moving forward? And will these things all become political decisions moving forward rather than science-based decisions?
How can we base them more off of science? Is there a way to fix that, or is there a way to focus more on health?
Well, as I said at the beginning, the public has gotten incredibly tired. We're all tired. And the public is at a point where many of them, you know, it's an imposition to wear a mask. It's an imposition to stay 6 feet away from people. They don't like being told in a strong suggestion in a high transmission area like Salt Lake County is, like most of the state is. You should limit your social gatherings to 10 people or fewer. And so they're expressing that frustration to their legislators, that it's an overreach, and our legislature is responding to those concerns, because that's the squeaky wheel right now, rather than striving to understand the science behind needing to do that. And it's obvious. If we practice good distancing, if we practice mask wearing, if we practice good hygiene, we can slow this down. We did it early on. We did it when we first implemented masks. We have staff similar to what takes place in the hospital that staff quarantine and isolation facilities. So we're there with a congregate group of individuals who are either positive or have been exposed, and because of the proper use of PPE and other protective measures, none of those staff have come down with COVID-19. These things work, but because we're tired as a society, we're not wanting to recognize the value of those things. We just want to get back to how things were before.
That's interesting. Are some of you seeing that as well? I know before, when we all got here, there was some conversation off camera about how many hours you've been working, and they were a lot. You guys are probably tired. Your staffs are probably tired. How are you seeing that coming into play here?
I think it's been a great benefit working from home for those of us that could, because I think it played a large part in exposure and in keeping people safe. But when you're home and all of the time when you're on complete lockdown, so I come from New York, and where I live, we were hit astronomically with COVID. We had, in the next town next to me, 68 out of 1,000 people were positive. That was our positivity rate. Our laboratory testing rates were 50, 60, 70% positives at one time. And a lot of people died. It was very early in the pandemic. We didn't know how to treat our patients. We didn't know what to do. We didn't have we didn't have PPE, enough ventilators and all of that. And so they went on really heavy lockdown, and it did work. If you look at it, it did work. But working from home is stressful. You find that you're working from 5 or 6 in the morning until 11 or 12 o'clock every single night. There is no break. You're home, you're stuck, and you work. So I think there's a lot of that mental fatigue that goes on, and I think that's part of why people just want to get out and have a normal life again. And we were doing this 7 days a week. But it did work. And, I commute back and forth between Salt Lake and New York. And when I went back to New York for the first time in June, after being here for 4 or 5 months because I couldn't get back to New York, nobody questioned anything. Everybody wore a mask. Nobody gave you a hard time if you went into a shop. Nobody had to ask to do it. Everything was pretty deserted, and people respected it, and I think that's because we lost so many people. But when you have areas that locked down very early, that didn't really feel that high medical impact like we did in New York, after a while they're saying, well, why are we doing this? We have no cases, it's very low. So now I think, unfortunately, Utah is seeing the result of that, because they were okay in the beginning. But now you're tired, you've been doing this for so many months, you want to be out in the open, and now it's spreading like crazy. And unfortunately, that's the concern, is that when you didn't have that huge impact in the beginning, people just didn't appreciate, people lost their grandmothers and their siblings, 2 or 3 people in the same family that died. So I think that was a real psychological impact in certain areas that I certainly do not want to see happen here in Salt Lake with the way the rates are going. But I'm really concerned with what's happening here. And as far as who to listen to the scientists, the medical people. You don't listen to the news, some broadcaster giving you advice on how you take care of COVID. You have to listen to the scientists and the medical people. They're the ones that know what they're talking about. And I think that's part of it. People listen to too much garbage on the news and don't really get the facts. And that's been a large part of it.
Yeah, we talk about the fatigue that we have, and if you want to see fatigue, go to our ICU. Go to our hospital units where we round and talk to those nurses, the respiratory techs. That's the fatigue you see, and it goes so far beyond just the physical fatigue, asking them to take more shifts or work longer hours or more often. It's also the mental fatigue that our caregivers are under when these people are in the hospital dying from COVID-19 and they can't have visitors. And so now you're asking a caregiver to have a Skype conversation with their loved ones to talk about end-of-life care. Now, that's not something you leave at the doors when you go home. Right? That's something you take with you as you go home. And unfortunately, we're getting very good at it. And so, when you talk about the fatigue of a caregiver, yes, we're asking them to work long hours, and they're stepping up and doing it because they know that's what they have to do and that's their role. But I continuously worry about just the mental exhaustion in terms of developing PTSD and taking care of these patients, and seeing so many of them die is really, really hard on our caregivers. And then they go home and they get on Facebook or they get on Twitter and they get on Instagram, or they hear national leaders tell us that this isn't a problem. And so that misinformation campaign that we internalize as scientists and as caregivers is just devastating to all of us, and it's just so insulting when we spend 7 days a week not with our families and being at work, and we're now confronted with this misinformation campaign, or we see it in our communities when people just push back against wearing a simple mask, or we tell somebody, no, you shouldn't congregate in thousands of people for a Halloween party. That shouldn't happen. That is so hard for caregivers, and that's one of, I think, our biggest challenges is how do you impact that misinformation campaign and get people to actually listen to their leaders that are knowledgeable in this topic.
So, based on what you said, some of what you said about politicizing this, do you think that there should be more lockdowns, that there should be more controls? I know this is, like you said, it's become a very political issue, but to some of your points, the lockdowns really worked. People are not adhering to guidelines, and that's some of what we're having the rush about. What is your take on that? What should be done here?
I've got a very clear opinion on this, so I'm happy to lead out, but I'd love to hear
Let's have our infectious disease
what everybody else
expert.
thinks. Our rate of community transmission is so high right now, and our test positivity rate is so high that we need aggressive measures, and we need them now. And so this isn't asking more people to wear masks or asking people not to gather and politely asking don't gather for these 1,000-person parties for Halloween. We need aggressive measures, and I think we think of this as all or nothing, right? But we can't think of that like all or nothing or a light switch. We can think about kind of gradations of an intervention. And so yeah, I think we all need to go home. I think we need to take at least 2 weeks of time where we just go out for essential activities. Maybe we say, okay, kids go to school, but there's absolutely no extracurricular activities. There's no sporting events. There's none of that. And we focus on acutely bringing down the community transmission rate. And if we do that and do it effectively, we can bring our community transmission rate not to zero. It'll still be present. We'll still see transmission. And then we may have to do that again in 2 months' time and take a 2-week pause. But we have to do something now to control the current pandemic, because we're at rates that are not sustainable.
One thing, it does seem, early through the summer, we did a series of webinars with our medical director is an epidemiologist, and I was amazed. We had hundreds and hundreds of employers who called in, and I think that the organized groups have done a great job responding to the pandemic. I think Utah's businesses have done a great job responding to the pandemic and saying, we want you to put on a mask because we want to stay open. And so I think we should acknowledge the good job that the overwhelming majority of Utah's businesses have done and really take on that personal responsibility and some of our social activities and things that we are tired and we want to get back to normal. But at least from what we've seen, I'm very impressed by how Utah's businesses have responded to the pandemic.
I agree. I don't think the issue's with the businesses. I think everybody's really concerned about protecting their own people, protecting the families that they go home to. I mean, the procedures that we put in place, we have to protect our workers, not only for their own health, but we can't shut down our facilities if we would have a huge COVID outbreak. That would be devastating for all the patients now that are not going to get testing and not going to do it. So I think as employers, we took this very, very seriously. And we look at that every single day. We just met yesterday and say, okay, and we went on a tighter lockdown than we had been because of the surge that we've seen. But it's really more in the community. I don't think it's in the business. It's when people go home and they want to go to a restaurant or they want to hang out at a bar. The young people don't feel it, they don't get sick as the older people do, but they're great, they spread the virus among other family members. So what type of lockdown? Do we need to go to 100% for a 2-week just to say, okay, time out, we need a break? Everybody criticized Cuomo when he shut down New York State. I mean, really criticized. And it was devastating on the economy. It really, really was. But that was almost a 4-month lockdown. But we would have had millions of people in New York City die if he hadn't done that. So you don't want to get to that point. If we could take maybe a 2-week break, that's a sustainable for businesses. But a 4-month, which is something that it could lead into, is really not sustainable. So maybe that timeout, we need a timeout is something that needs to be considered, but it has to be mandated and enforced by the government of the state. Our employees do well, we ask them what to do, but we can't govern if they go home and they go to a party or they go to a soccer game or they do whatever. So, it's really difficult.
Yeah, and I think that point of a 2-week pause, that's the incubation period of the virus. That would do so much for us and allow the economy to continue to do well. I would actually argue that you would be doing a benefit to the economy by taking a 2-week pause, because it would drive your cases lower where people could then more safely move about for a period of time. Because you're right, our businesses have done tremendous jobs, and there's businesses out there that I will continue to frequent because of the efforts they've done during this pandemic. But I think that's the point, is that a temporary pause to control the community-based transmission, whether it be 2 weeks or 3 weeks, or it's data-driven, is going to be critical to allow our businesses to flourish, especially as we move into the holiday season. Now is really the time to do this for our retail businesses, so we have community transmission rates that we can manage, both from a hospital and a testing standpoint, to get us to move forward. And it may not be the only pause we put into place. Maybe it's something we institute now, and then in January we have to do the same thing. And there's very good data to support this. Other countries have done it. Europe is currently doing it, and then the model-based algorithms look really good. So this isn't a hypothesis like, oh, this could work. This is proven to be effective, but we need to be able to implement it widely and consistently for it to have any benefit at all.
Is this even a possibility? Gary, you're in all the conversations. What's happening?
Well, there are always discussions on what do we need to do, because where we are doesn't seem to be working. I agree completely. Our businesses have been so innovative and so responsive. We receive numerous calls every day, complaints about a business. We go and we visit with that business, and they are so open to suggestions that we can give and just what they need to do to implement, because they know they need to keep their employees and their customers safe. They have every desire to do that. I am so amazed at the innovation that the food service industry has done throughout all of this. In fact, I wonder if some of them will ever go back to in-house dining. That's one less hassle they have to worry about, this bussing tables and all of that. So, and they've adopted some really good models. I'm accused by my kids of having been the pioneer of social distancing. They say, well, this just fits right with you. And so it hasn't been a challenge for me. If I have something that I need, essential, I go to the store, I get it, I wear my mask, I stay away from people. You know, I don't have a lot of people that come and visit me, and I don't go and visit a lot of people. So it hasn't been hard for me, but I know that I'm different that way. And a lot of our public struggles with not being able to have that social contact, which has surprised me somewhat because so many of our young people are so tied to the electronic way of communicating, but I've learned that no, they also really need that social interaction that's not electronic. I think we can individually take that 2-week pause if we will be disciplined enough to do it. To say, okay, I will go out for the essential things, but I'm not going to just go out to be out.
But you're saying that probably won't be enforced from the city, from the state, where we probably won't go back to that again?
I'm not saying it won't be, but I don't know that it's on anybody's immediate plan to do that.
Okay, interesting. So there's some want for some tighter controls, some maybe public rebellion against that, and some politicization that's making it kind of difficult. So where is there some kind of compromise we can come to going forward? Is there some way that we can, you know, get these controls in place without the control or the appearance of it?
Well, I would just again say, and these are things that many of our elected officials have said, we all have a personal responsibility for our neighbors, for our families. And even though it's not as comfortable as we would like, it's not as loving, perhaps, as we would like it to be. We want to go and take that meal to our neighbor who had surgery. We need to figure out different ways to do that. And if we will continue this for, I would like to say a little bit longer, it's probably longer than we all want it to be, we will see progress with this surge that we're in right now. But we all have to assume that responsibility. It's not just your responsibility, it's my responsibility.
Okay, so left up to the individual?
Yeah, I mean, I think that's challenging because that's the call we've been making. That's the call we've been making since, you know, the Mask Up Utah campaign this summer, and you know, you hear pleas from healthcare workers at the governor's press conference on Thursdays, and you know, the pessimist in me says, well, what's going to change now? We need something to help us change. And you know, maybe that is getting a groundswell of support from our business leaders, from the Chamber of Commerce, from the Utah businesses that say, hey, there's a really critical point coming up for us in this business season, and that's the holiday season. Maybe we can develop a groundswell of support to get our elected officials to move in this direction. Maybe it's relying on some large churches or members of faith in this community to push in this direction. We need to look at what levers can we pull to change behavior. Because in my mind, having been doing this now since March, you know, we haven't made a whole lot of inroads. And it's clearly people are fatigued and people are exhausted and they don't want to hear it. And so how do we really influence, and who are the influential peoples in our community that can help change behavior? And I mean, I think the Utah Department of Health has done just a tremendous job, but we need to help them now, and maybe that starts with our business leaders.
So the business community kind of stepping up and asking for some space before the holidays. I like that. So we're imagining a holiday season that is a little bit overwhelmed with COVID cases. We've got winter approaching. We're all kind of in this holding pattern until we're hoping some kind of vaccine happens. Is that kind of the way of things at this point, that it's got to kind of stay like this until we get a vaccine before we can even start thinking about what changes are going to be made? Or are we already kind of anticipating what we're going to do once we've got vaccines in place?
Well, I mean, I think that we have spoken a lot that we are still in a crisis, but I do think that long term, all of us are thinking about how do we build a better healthcare future so that people have access to better, simpler, more affordable care that is coordinated and works for them, and that work isn't going to stop. But I think as we started this second hour, it is hard to think too much about that in a time of crisis, but that is the direction we're going to go, and in some ways the crisis will push us there, right? I mean, because of things that have come out on exposing inequities in the healthcare system and barriers to care that have existed and have been made amplified over the past year. But we're all going to be working on those, and that work doesn't stop.
So at your organization, do you imagine all of your employees coming back to the office once there's a vaccine?
So, we've taken a slow approach to that, and one other thing is, we operate in multiple states that are in different positions and have different political realities about reopening, and we've wanted to communicate to employees with multiple months of advance warning. So I don't know if it'll be a vaccine, but it will be a scenario where the pandemic is under control, where schools are open, and recognizing the burdens that are on our employees and their families right now. So I think that that's not a decision that we're going to rush into, but I don't expect it will happen too soon.
Yeah.
So just a note about vaccination. I think if people think that this is the way COVID is going to end, I think they're putting a lot of faith in something that we don't know a lot about right now. We have no idea on the protective nature of the vaccines. How well will the elderly do with the vaccines? They don't even do well with influenza. You get a double strain shot, for influenza in the elderly. How long will it be protective? And there's this whole movement in this country against vaccination. I mean, we had huge measles outbreaks in New York this year because we have whole populations that refuse to vaccinate their children. We can't get people to get a flu vaccine. Maybe they'll be a little bit more scared this year because it's COVID, and they'll think about it. But COVID is a 2-dose vaccine. You can't even get people in for a first dose, let alone how do you schedule, make sure they come back in 3 weeks for their second dose. And you're going to have a whole huge part of the population that will refuse to be vaccinated. So, I mean, I will get my vaccination, believe me, the minute it's available, but a lot of people are very unhappy about vaccination. And you can't mandate people get vaccinated, not even for the schools. They have the option, we had the huge measles outbreak in New York, and we had, you can get exempt from vaccines for many reasons. And that now, the choice is you have to homeschool because of the huge measles outbreaks that we had in New York City. So you can't mandate it. In the private sector, like in businesses, we can't mandate that our employees get vaccinated or their families. I mean, even in the hospital, it wasn't mandatory, but it was kind of mandatory. So in my healthcare system, if you refused to get your influenza shot, or maybe for health reasons you couldn't get it, you had to wear an N95 mask all the time if you had any patient contact. So in the private sector, I think it's going to be extremely difficult to mandate vaccination. And I'm not sure what they're predicting, but I think we would be really doing well if we had a 50% vaccination rate, really, really well. And that leaves another 50% of the population exposed and transmit to other people. So people are proposing it as the solution to COVID. People got to be really careful. It's not going to be the answer. It'll certainly help, but it's not going to be the answer for this winter for sure.
Did you have something you wanted to add?
One of the things that we haven't discussed that I think would help all of us as an employer and as a educator with numbers of students in these populations that aren't complying with it is rapid testing. And we really haven't employed those things, which would be easy, something that we can do within 10 to 15 minutes, that is inexpensive for us to do and do large-scale rapid testing, would help us know and segregate those individuals with doing. You know, we're frustrated, you know, it's compliance is very difficult, we can't get, but testing would at least be able to, for us to identify and segregate those individuals very quickly. And I think that's something that we're looking at as we go forward when we do this. That would help us be able to do it, get past those that don't want vaccination, get past those that don't want to comply, and we can still keep everybody safe with that. So.
Okay, rapid testing being, we can ensure that these individuals don't have COVID even if they don't have.
Right, so we would use it as a screening, so we would see what's going on. We could screen a large population of those individuals. You could, if it's home testing, you could do it before you go see grandma and grandpa so that you know that you're safe before you go see them. And then if you do get a positive test, we want you to follow up with your primary care physician and make sure that you're doing everything you should with that and maybe get tested under other more definitive testing than for diagnosis. But as a rapid screening tool, this would really help us and be more accurate.
Yeah, I completely agree. I mean, I think as we look forward, vaccination will have a role, hopefully. I mean, most vaccines that go through trials fail. We've got a lot in phase 3 trial. We hope that, you know, based on phase 1, phase 2 study, they look promising, but we haven't seen any data yet to say whether or not it's effective. And the first data we get isn't going to be the data we want. We want to know, does it reduce hospitalizations? Does it reduce deaths? And that's not data we're probably going to have initially. And given the vaccine hesitancy in our communities and also across the US, this isn't going to be a magic bullet, you know, and it's most likely not going to be a vaccine that's as equivalent and as good as like measles vaccine, hepatitis B vaccine, excellent vaccines, 95% efficacy. This is most likely going to be like a flu vaccine in terms of how well it is effective. So that's going to be, I think, one arm of the way we approach this. And then the other arms are going to be testing and therapeutics. And so I do think that routine serial testing would be something that would definitely be integrated into schools where, you know, your child gets up, they do a swab, oh, I'm negative today, I go to school. And maybe they're testing that isn't as sensitive as these specific PCR-based tests, but they're good enough to detect high levels of virus in your nose that would transmit. And if you do it serially, you can then say, oh, I've got a positive, I'm going online today and joining my class that way. And so I do think that is where diagnostic tests are going, and you see a number of manufacturers going into these antigen tests and even point-of-care tests or potentially testing you at the home. And then therapeutics, I think we're going to see more and more coming out of monoclonal antibodies. These are the antibodies that are specific to SARS-CoV-2, the spike protein on the virus, that if given early, likely are going to be of a benefit. And we're going to, I think, see those move into the outpatient. And so that you can get a rapid test, get potentially a monoclonal antibody, and then that would prevent hospitalization. So I do think that this isn't going to be a single intervention. This is going to be vaccines, it's going to be testing, it's going to be diagnostics, and we can't forget there's going to be always a component of public health in terms of some of these, you know, large gatherings, and masks aren't going to go away, and we're going to have masks in our life for quite some time.
Can you explain more of the antibody part? Not quite following.
Sure. So when people are infected with SARS-CoV-2, we develop antibodies. That's a way that our body essentially identifies the virus and takes it out of circulation. Is a way to think about it. And that's how we identify people that have gotten sick. And what we've done now is we haven't done this, the greater scientific we have identified specific antibodies and manufactured them so then if somebody gets sick, then we can give them that antibody and it potentially is going to hasten their illness. And ideally, it would prevent hospitalization and death. So it's a therapeutic that would be given, it's a monoclonal antibody, but that also brings in a lot of operational challenges in terms of somebody getting diagnosed, finding out 24 hours later, they're infectious. Where do they go to get this infused? There's transfusion reaction. Who's going to pay for this probably very expensive antibody that the government will probably pay for the first little bit, but then it's going to be put on payers. And so the ripple effect of this type of therapy is going to be really challenging for all of us to figure out in healthcare.
And none of this is stuff we have yet. This rapid test, this antibody, this is future talk.
I just want to have a cautionary measure, and it has to be a combination of measures. We know very clearly you can be negative today and you're positive tomorrow. And that day before you came positive, you're highly infectious. So one of the problems with doing this type of testing, and we've had super spreader events that were the result of this, is that people sometimes get a false security. Oh, I had my test, I'm negative. I can go visit grandma and grandpa, and we can have that party. I heard a group of people the other day saying, oh yeah, we're gonna have a party. Everybody's gonna go 3 days before and have their COVID test so we can have this big party. And that's what people have to understand also. It's a great screening tool. I think it has a great place if you do it serially. But that one-shot negative COVID test doesn't mean that you're not infectious. That doesn't mean you don't have to wear your mask or you don't wash your hands. But the general public don't understand this. There's a lot of education. All they say is, oh, my COVID test is negative, I'm fine. So we have to be extremely careful, and particularly with rapid antigen tests, that we know we're going to be a lot less sensitive than a PCR test. You may not technically be as infectious with as much virus, but we don't even know that for sure either. So it has to be this package, this combination, that people really can't let their guard down. They still have to do the other things that they need to do.
Stephen, were you about to?
Yeah, it's a very similar point that businesses, there have been very prominent super spreader events at workplaces where rapid testing on a daily basis was employed, and so that was the exact point, was that it can project a false sense of security, and we still have to remain vigilant in our workplaces and in our social interactions, even as we increase adoption of those types of tools.
So are we preparing for some kind of future in which we'll have these rapid testing, we'll be able to do this, where we have these antibodies? Are these things we're actively preparing for?
Well, there are rapid tests available now. They're not necessarily available, I don't believe, on the over-the-counter market. Is that correct? Okay. But rapid testing technology is there. There are new reports almost every day of a new rapid test that is under development. We are employing rapid tests right now, primarily with the school-age population, to help with some of this. It's the policy that the state has adopted called test and return. Students are quarantined. They can, after a period of time, get a test, and if they're negative, and there's the concern because they could still turn positive, but if they're negative, they could return to school, because we want to keep the kids back, we want to get the kids back in school. So that technology is there, continuing to be developed, and I'm sure before long it will be available, so you can go and purchase tests over the counter and use in-home.
So this is how we're imagining our 2021. Is there anything we can really leave this on a positive note and say that we're really looking forward to in 2021?
I've been talking about the innovations. There are many businesses that have pivoted. They talked about the PPE pivot early on in the pandemic, the types of medical interventions that have come out. I think that we have a lot to be optimistic about as a country and as a business community, that this will foster a lot of innovation about how we do business and how we deliver medical care over the next several years. So I'm going to be optimistic about the future, and I think many more good things will come from COVID than negative things.
This isn't business related, but I think many families have reconnected, parents with their children. The kids are not going in a million different directions. They're spending time at home together. And I think that's going to benefit our society in the long run.
I think, as we look forward, we have learned so much about this virus. And so is next year's 2021 going to be better than 2020? Yeah, no doubt about it. So I think we can look forward to that. And the fact that we know how to manage this from a public health standpoint. We have therapeutics now that work. We have testing and testing capabilities that are coming on board for mass testing. And we have vaccination that is actually probably right around the corner in a number of weeks, potentially, for coming to some parts of our communities. So yeah, it's going to be better, but it's not going to be back to normal. It's going to be our next normal of what we can expect with this virus. And you're right, the innovation that has come through education and how we train our medical residents and medical students or pharmacists or dentists has just been phenomenal. And those innovations are going to continue. Telehealth is going to continue to push forward, and we're going to have a more friendly healthcare environment that I'm hoping is simpler and easier and cheaper to navigate. So I think 2021 is going to look better than 2020. And I'm hoping that the stress on our healthcare networks is going to be a lot less because of all of these multifaceted interventions we're going to implement. But it's not going to be it's not going to be 2018. It's going to be 2021. It's going to have its uniqueness, but it'll be better than 2020.
Okay, I like that. I think that we've certainly seen a lot of that innovation you're talking about in the business communities. We've seen a lot of businesses not only pivot to help the medical communities, but also pivot their business models. Ghost restaurants are starting to be a thing where they're literally just sharing an industrial kitchen, and there is no, dining room. And all these businesses are coming out with these new ideas, which I think are definitely very innovative and will be very interesting for our future. So I'm very excited about that. Well, thank you all so much for being here with us today. It was really awesome. I know it's quite difficult time to all get together in person, but I think it really fostered some good conversation, hopefully gave our listeners and watchers at home something to think about. Thank you guys so much. I really appreciate it. And thank you so much for being part of our first live stream. We'll be back with several more of these in 2021. We'll see you there. Thanks.